Welcome to clinical presentations of disease in AIAN populations. By the end of this session, participants will be able to identify and analyze issues in diagnosing, treating, and preventing diseases in Indigenous patients, demonstrate understanding of age-related morbidity differences and their impact on client care, describe the concept of social and emotional well-being, and apply culturally safe practices. Identify and analyze community-wide approaches to disease prevention among AIAN populations. AIAN communities encompass over 570 federally recognized tribes across the United States, each with its own distinct language, cultural traditions, and geographic context. Some communities live on reservations, others in urban centers or rural areas. Despite their rich diversity, these populations face significant health disparities, many rooted in historical trauma, systemic inequities, and limited access to quality healthcare. As health professionals, understanding these dynamics is key to delivering culturally responsive care that respects identity, honors lived experience, and promotes healing. We must understand the role of history to fully grasp current health outcomes in AIAN populations. Colonization disrupted traditional ways of life, leading to land dispossession, loss of food sovereignty, and environmental degradation. Boarding schools, designed to assimilate Indigenous children by erasing their languages and cultures, caused lasting psychological and intergenerational trauma. Forced relocation policies and urbanization efforts further severed people from their communities and cultural supports. This cumulative trauma continues to impact mental and physical health today. Recognizing this history helps us understand why some individuals may distrust the healthcare system, avoid screenings, or resist Western medical interventions. Today, AIAN individuals face disproportionately high rates of chronic illness, including type 2 diabetes, cardiovascular disease, and chronic liver disease. Mental health concerns like depression and suicide are also alarmingly prevalent. Life expectancy for AIAN individuals is approximately 5.5 years less than the US average. For example, men live an average of 65 years compared to 76 nationally, and women live 71 versus 81. Contributing factors include poverty, limited access to healthy foods, lack of preventive care, and insufficient behavioral health services. Many communities are located in rural areas with few healthcare facilities and long travel distances to specialty care. These are not just statistics. They represent real lives affected by systemic neglect. The primary healthcare delivery systems serving AIAN populations include Indian Health Service, IHS, a federal agency providing direct medical services to enrolled members of federally recognized tribes. Tribal health programs, tribally operated clinics and hospitals that offer culturally appropriate care tailored to specific communities. Urban Indian Organizations, UIOs, nonprofit entities serving AIAN individuals living in cities who may not have access to IHS or tribal facilities. While these systems are vital lifelines, they often operate under severe funding limitations and staffing shortages. This affects wait times, continuity of care, and access to specialists. Providers working outside these systems need to understand how to coordinate care with them and advocate for improved resources. Cultural differences can significantly influence how symptoms are expressed and interpreted. In many Indigenous cultures, emotional distress is often somatized, expressed through physical complaints such as headaches, fatigue, or stomach pain. Mental health stigma can be compounded when Western diagnostic frameworks are applied without consideration of traditional beliefs. Some communities view depression or anxiety as spiritual imbalances rather than psychiatric illnesses. Traditional healing practices, including ceremonies, herbal medicine, sweat lodges, and consultation with elders, are highly valued. Integrating these practices into mainstream care when appropriate can enhance engagement and treatment adherence. The provider's responsibility is not to replace traditional healing, but to collaborate respectfully and inclusively. English may not be the first language for many AIAN patients. Even when it is, communication styles, dialects, and idiomatic expressions can vary widely. Health literacy levels may be low, especially in older adults or those living in remote areas. Culturally relevant educational materials are often scarce or non-existent. When using interpreters, ensure they are trained and familiar with both the language and cultural nuances. Avoid literal translations that miss the intended meaning. Always confirm understanding through teach-back methods and open-ended questions. Implicit bias affects all of us, even those with the best intentions. Research shows that unconscious assumptions can lead to lower pain assessment scores, delayed referrals for specialty care, misinterpretation of culturally grounded behaviors as noncompliance or aggression. These oversights can result in substandard care and reinforce existing mistrust in the system. Training in cultural humility and anti-bias practices is essential for all healthcare staff working with Indigenous populations. AIAN populations experience health challenges across the lifespan. Infants and mothers face higher rates of preterm birth, low birth weight, and maternal complications. Youth struggle with early onset diabetes, suicide, and substance use disorders. Adults develop chronic diseases at younger ages than the general population. Elders often live with multiple comorbidities, experience isolation, and have unmet spiritual care needs. A life course approach enables us to address these issues proactively, tailoring interventions to developmental stages and cultural contexts. Many AIAN people live in rural or remote areas with limited access to hospitals, specialists, or pharmacies. Transportation issues, especially for elderly patients, can prevent regular follow-ups, medication pickup, or participation in wellness programs. Insurance coverage is inconsistent. While IHS provides basic services, it does not cover everything. Private insurance options may be too costly or unavailable. These structural barriers must be factored into discharge planning, care coordination, and referral processes. AIAN communities are frequently excluded from clinical trials and research studies. This exclusion leads to lack of evidence-based guidelines for Indigenous populations, misunderstanding of disease prevalence and treatment patterns, fewer resources tailored to community-specific needs. Without data, policy decisions and treatment protocols remain generic and ineffective. Advocating for inclusive research and collaborating with tribal institutional review boards, IRBs, is essential for equitable healthcare development. Let's walk through a case study together. Imagine a 45-year-old Ojibwe woman presenting with fatigue, weight gain, and depression. She has a strong family history of diabetes, but avoids screening due to past negative experiences with the healthcare system. How might her cultural beliefs influence how she describes her symptoms? What factors contribute to her reluctance to seek care? Consider how integrating traditional healing, such as consulting with a medicine person or participating in a smudging ceremony, could build trust and improve engagement. This case highlights the importance of cultural sensitivity, trauma-informed care, and collaborative decision-making. Mental health concerns appear differently across the lifespan. Children may exhibit behavioral problems stemming from trauma or disrupted attachment. Youth struggle with emotional and psychological stress, identity confusion, and peer pressure. Adults carry the burden of historical trauma, poverty, and intergenerational grief. Elders experience loss of loved ones, changes in role, and spiritual transitions. Effective care involves tailoring age-specific tools, engaging families and communities, integrating behavioral health services into primary care. Symptoms of depression, anxiety, or trauma may be expressed differently due to cultural norms around emotional expression, historical and intergenerational trauma and stigma associated with Western behavioral health services. Example: in some communities, emotional distress may manifest as somatic complaints, for example, headaches, fatigue, which can be misinterpreted by providers unfamiliar with these patterns. AIAN communities embrace holistic models of health that integrate body, mind, spirit, and environment. Many AIAN communities incorporate traditional healing practices alongside Western medicine. These may include smudging ceremonies, sweat lodges, talking circles, storytelling, and oral traditions, use of medicinal plants. Integrating traditional healing with modern medicine can enhance trust, improve engagement, and promote recovery. Substance use often intersects with unresolved historical trauma and current stressors such as poverty, discrimination, and loss of culture. Prevention and treatment must address grief and loss, identity disconnection, and community fragmentation. Culturally safe care moves beyond competence. It prioritizes safety, respect, and humility. It requires self-reflection by providers regarding their own biases and privilege. It centers the patient's worldview, even if it differs from the provider's. It promotes shared decision-making and respect for Indigenous knowledge systems. Best practices for culturally safe care. Ask patients about their beliefs and preferred healing methods. Collaborate with tribal elders, healers, or cultural liaisons when appropriate. Offer care plans that integrate both Western and traditional practices. Provide training for staff on historical trauma and its impacts. Effective prevention efforts in AIAN communities are most successful when they are tribally driven, culturally grounded, and community-led. These initiatives recognize the importance of self-determination, cultural revitalization, and collective healing. Strengths-based approaches, rather than focusing only on risk factors, strengths-based strategies highlight cultural identity, language preservation, land-based education, elders as knowledge keepers, youth engagement, and mentorship. Examples of successful programs include programs like the Traditional Foods Project, supported by the USDA, Indian Health Service, and tribal governments, promote healthier diets through gardening and farming using ancestral methods, food sovereignty movements, revival of food-sharing networks, youth suicide prevention initiatives such as the Wiconi Project, Lakota for Life, in ND that focus on reconnecting youth with cultural teachings, mentorship by elders and spiritual leaders, creating safe spaces for storytelling and healing, tobacco cessation with cultural sensitivity. Tobacco has sacred ceremonial use in many tribes. Effective cessation programs distinguish between sacred use versus commercial tobacco, harm reduction versus total abstinence. Examples: not on tobacco, not program adaptations tailored to AIAN youth, trauma-informed community wellness centers. Some tribes have established wellness centers combining behavioral health services, traditional healing, physical activity, nutrition support, peer counseling, and recovery support. These models demonstrate what happens when culture and community guide health interventions. Now, let's apply what we've learned. Imagine you are part of a planning team working with a tribal community to develop a wellness initiative targeting youth substance misuse. Your goal is to create a program that is culturally relevant, age-appropriate, sustained through community leadership. Questions to guide your planning. What cultural values will guide the program? Who are the key stakeholders, elders, youth, educators? How will success be measured? How will the program be funded and sustained? This activity encourages thinking beyond clinical walls and into the heart of the community. In summary, AIAN health cannot be understood without considering historical and cultural contexts. Effective prevention and treatment must be community-led and culturally safe. Holistic wellness includes physical, emotional, and spiritual dimensions. As providers, we are partners in health, not saviors. Our responsibility is to listen deeply, reflect honestly, and act respectfully. These are the additional resources. Thank you for listening to this presentation.